Okay, so in a sense, we really have talked about practice, haven't we?
Mm-hmm.
We really, is there anything else that you would like to tell us about practice, how comfort has been advanced in practice, and its application to a variety of settings?
Well, as you know, when we were both full-time teachers, we applied comfort theory in the community, and we had students do a community assessment of comfort needs in that community and how well the community met those needs. That was very interesting.
Yes, that was interesting.
We do it at the hospital-wide level, and the individual level, of course, when we work with our own patients, instead of using research questionnaires, we can ask them in clinical practice, how would you rate your comfort from 0 to 10, with 10 being the best possible comfort in the situation?
So in a sense, are you talking about that as a measure like the pain
Yes.
scale that they have?
Yes. And I would say that pain is a part of comfort. Pain management is a part of comfort management, but it's not the only part. We can also do things like back rubs, active listening, referral to a social worker, cleaning up the room, getting the noise level down, that will make the pain level decrease
Yes.
in conjunction with pain medication. And it is probably, with research, you could show that some of these non-medicine interventions decrease the need for high dosages of pain medications. So which is healthier for the patient when you're using heavy narcotics.
Yes.
So,
And also the bottom line of economics.
right. So I would advocate doing a comfort verbal rating scale right along with a pain verbal rating scale.
So make it the 7th vital sign?
Right, exactly. You might not want to do it as often as you do pain because right now JACO mandates, I think, every 4 hours and 20 minutes after medication has been given. But you might just do a comfort verbal rating from the patient at the beginning of each shift. Comfort theory can also undergird patient rounds. And instead of kind of a systems approach to rounding, you could do a comfort needs approach. I advocate using comfort theory to decrease the amount of charting and documentation and pages and pages and pages in the patient's record. And I think when you document comfort needs, you really get a very individualized picture of the patient, more so than going through systems.
Yes. Because comfort is such a holistic concept,
Right.
and it addresses the individual.
Right. And it captures their individual needs, their family situation, their financial situation. It's all there. One of the big complaints that doctors make about going to all electronic charting is that the present system that we have doesn't give a picture of the patient. That one chart looks like another chart, looks like another chart, looks like another chart. And so, we're not capturing the individualized patient as a whole person in our current documentation. So this theory would be an antidote to that as well.
Yes. Right. So there's a lot to be done yet in the
Yes, there
practice
is.
field. Yes, there's a lot to be done. Okay. Now we also want to talk about education and how is this used? I know you've been teaching theory in for a number of years, and that you talk about theory development and your concept of theory of comfort. But also, how do you see it, envision it for education in life?
Okay.
And you've done some of that with hospitals, it seems,
Yeah.
but not with.
Well, I envision it two ways when we're working with undergraduate students in nursing schools. first of all, what I did when I had my clinical students, and that was in a gerontology setting, I had them do comfort care plans, which are on my website. And they had to fill in the comfort needs of their patients in a column: the physical, psychospiritual, sociocultural, environmental comfort needs. In another column, what they did about those needs. In another column, the intervening variables that the nurses couldn't do much about, like their financial situation, their family life, their diagnosis. Because those factors will also impact on the success of your comfort care plan. And then an assessment of their comfort before and after this holistic type of nursing was applied. So a lot of these interventions can be done at the same time, in the same interaction with a patient. They can be picking up the clutter, and they're looking at the patient's face and assessing their psychological well-being as well as their physical function, their appetites, toileting them, getting them well positioned in bed. So all of these interactions are done at the same time. It's very efficient, and the student leaves feeling very satisfied. The patients love it, and they can actually document that the patient said she was more comfortable after the student was there. So, and then they, together with the patient, were to identify health-seeking behaviors and desired by the patient for the patient's own rehabilitation needs or comfort management needs. So that's one way to use it. Another way to use it is captured in this article by Mickey Goodwin in India Center. It is 2008, I think, article, and it's on my website as well.
In the Journal of Holistic Nursing.
Journal of Holistic Nursing. They implemented an intervention for all of the baccalaureate students at their college, where the faculty viewed students as the recipients of care and measured the students' comfort with their nursing program. And each of the nice, thoughtful things that faculty do that are largely invisible were considered interventions, holistic interventions, geared to the individual needs of the students. And so they applied the theory in kind of a macro way to the students in their college. And I thought that was a really interesting idea.
Be useful for people on promotion and tenure track too,
yes, and it's a good example for mentoring students, and for the later preceptors that they have when they are in their senior year. Everybody should be trying to nurture these new nurses,
yes,
including faculty, and then the preceptors and the mentors, and so that these new nurses can in turn be good mentors and preceptors to the next generation of nurses.
It's giving voice to what faculty do who really produce these students. It's giving a clarity so that faculty can identify this is an appropriate intervention here for this person. She needs more
Well, and I
comfort
think
here.
it role models caring.
Yes.
And as a profession, if we don't role model caring to our students, how can we expect them to be caring when they are engaged in nursing as graduates? So it's I think of it as a kinder, gentler way to teach nurses
Yes.
how to be holistic nurses.
Excellent.
So those are two ways that I can see the theory being used in education.